So some big developments, a lot of options, which also means that there are probably a lot of studies we still need to do down the road to sort out how best to use these. Let's talk just a little bit about what's going on. And Rod, you had just alluded to one of those studies, which is the Cooperate 2 study.
Yes.
So that's a study looking at pasireotide?
Pasireotide plus or minus everolimus. It's obviously not blinded. We did not have a placebo shot to give patients who weren't going to receive real pasireotide, so it's open label in that respect. And I think a concern we have within the trial is that pasireotide may cause more hyperglycemia in patients than we have seen with octreotide, and that can be a factor for patients who've had primary pancreatic resections and may have lost a major portion of their pancreas in the past, and therefore may be a little more prone to that. And so we will see how that pans out.
I can add that there is another very similarly designed study being done through the cooperative groups right now, which is everolimus with or without bevacizumab. So that is asking whether bevacizumab, another angiogenesis inhibitor, might add to the activity of everolimus, really going down the road of combination therapy to see if we can enhance efficacy.
Yes.
There is a broader question, though, that often comes up, and that is perhaps specific to neuroendocrine tumors, given the sometimes prolonged time course, whether adding all these therapies together makes sense or whether sequential therapy makes more sense. Diane, it's perhaps a philosophical question, but what are your thoughts there?
I think that the sequential, and again, in the absence of data, I'm going to make my best guess here, but for example, extrapolating from breast cancer, which can also be more sometimes indolent, I think that they've proven with very large randomized controlled trials that single agent therapy is probably just as good as combination. And I envision our disease to be very similar, and that, certainly we will have patients like in our case study where they have a lot of tumor burden, they're sick, and they need a good treatment. So in that patient, I would, certainly opt for a combination of therapies. But in the patients that are having disease progression and under observation or on somatostatin analogs, I think it would be very appropriate to consider single agent in that patient.
So I think this has been a great discussion. Thank you, all of you. We've reviewed and discussed a lot of information about some of the new treatments and how we might be using some of these treatments in our patients. I thought we'd just go through and get some closing thoughts from everyone. And John, you want to have any closing thoughts or summary thoughts about the discussion today?
Well, I think there's been more progress in neuroendocrine tumors than almost any other gastrointestinal cancer. So it's very exciting to have all these new drugs and options, and we really need to learn how to sequence them. One class of therapy that hasn't really been mentioned here but is looking exciting is radiolabeled somatostatin analog therapy. That's a treatment that's been available for patients in Europe and hopefully will be available for American patients sometime in the coming years.
Diane?
Yeah, to echo that, I think that this is a very exciting time for us to be treating pancreatic neuroendocrine tumors. It's extremely rewarding that we have these options to provide for our patients, and to see some of the responses and how well they feel certainly keeps us going for all the other cancers that we take care of where the patients don't do nearly as well. I think another big struggle and challenge is to sort of better define our treatment options for the extrapancreatic neuroendocrine tumors, and we just haven't gotten there yet. So Radiant-4, for example, is asking the question of everolimus in non-pancreatic neuroendocrine tumors, and that has completed accrual, so we'll see what those results are. But our treatment options are much more limited in that situation, so hopefully that'll be the next year or two of different drugs in those patients.
And Rod, how have all these advances affected your practice? As a surgical oncologist, you have a unique perspective here.
Well, I would again echo that try wearing a different hat when you first look at the patient and realize that they may be more of a surgical candidate than you would think in terms of other kinds of classic types of tumors. And also to consider revisiting that after you've done some initial systemic therapies that may in fact open up surgical options for the patient again. And I think the important message is just what we've said. We now have a number of agents that we can have, and while we don't yet know the ultimate sequencing, I think we can anticipate that the majority of our patients will have an opportunity to benefit from each of these treatments in turn.
Thank you. A great summary. On behalf of our panel, we thank you for joining us. We hope that you found this peer exchange informative. and thank you again for your attention.